Okay, so we are going to start this case, the hybrid DES plus DCB in complex PCI with the presence of Dr. Ngọc from Hanoi.
Thank you, Mr. Chairman and the panelists. So we start with the hybrid DES plus DCB in the complex PCI. We have nothing to declare for disclosure. So the concept of complex hybrids and indicated PCI was originated since 2016. So it's kind of nearly 10 years ago. And the chip is not uncommon in our daily practice. And we have three spheres of chips, which is based on the patient's aspect, the anatomy of the coronary vessel, and also for hemodynamic status. And we have a lot of data from the patient characteristic and also the anatomy. But in terms of hemodynamics aspect, we have quite limited data. And the PCI strategy for these chips patients, we have like DS only, hybrid, which is DS plus DCB, and DCB only. So why chips matter? Because the more chips factor we have, the more adverse events we will face in the daily practice. And as you can see that if the patient had more chips factor, they will face with the higher mortality rates, the higher bleeding risk, and also the total MA is increasing significantly. And the chip factor fluctuate from a different group age, like for less than 65 to 75, and more than 75 years old, and variety among age groups. And what the advantages and the limitation of DCB in the chips PCI? The advantages we have, of course, we will reduce the number of stents used, so the stent burden is decreasing and stent-related reverse adverse events will significantly reduce. And the potential less aggressive DAPT regimens, especially for patients with high bleeding risk and elderly patients. And also reduce inflammatory response with uncaging of vessel. But the limitation is our data is just mostly observational and a variety of high variety of study designs, and no consensus on DAPT regimen duration for this group of patients. And for the bifurcation, we have hybrid for bifurcation in chips, which we focus on the main branch for stenting and the side branch for DCB. And even we have both main branch and side branch DCB both. And this is the latest recommendation from Euro intervention in 2025. And for the CTO lesion, which is previously quite limited data, and in this year in 2025, we have drug-coated balloon and versus hybrid strategy, and versus drug-eluting stent in CTO group patients, and this is a quite a large systematic review and meta-analysis. And they concluded that among more than 2,000 patients undergoing CTO PCI with DCB hybrid strategy, comparing to DES strategy, there is no significant difference in clinical outcomes between DCB hybrid comparing to DES strategy in CTO patients. So this is quite a promising data that we can apply to our daily practice for these complicated lesions as well. And also DCB, which is clearly indicated for small vessel disease and in-stent restenosis. But how about the large vessel disease? And from our colleagues in Korea, we have data for large vessel coronary artery disease, where they compare DCB strategy comparing to the DES, and amazingly, the MACE and the rate of revascularization is lower in the DCB group, and there is no significant difference in myocardial infarction and cardiac death comparing to the stent group. So we can apply DCB without worrying too much about the myocardial infarction and cardiac death in this group as well. And, and another data for the DCB in the myocardial infarction. This is the latest data from colleagues in Japan in 2025. They have all variety of patients even in STEMI and non-STEMI, and it's minor or major territory coronary, which is the corporate lesion. And the comparing and the data show that the DCB is favorable comparing to the DS. And some of the cases we have are in our daily practice, and we have bifurcation lesion with the very high risk patient, CHIPS with 79 years old lady, and hypertension, diabetics, and the 3 vessel disease, and stent with the right RCA like a month ago, and preserved ejection fraction. And we try to fix the LAD, which is quite angulated and severe calcification. We did 2 stents from the LAD to from the mid LAD to the proximal, and also we try to fix the left main because based on the IVUS finding. What is the role of DCB in this case? We want to show is like a bailout DCB strategy. We missed the side branch, which is no flow after we put the stent in from the left main to the proximal LAD. And then we pre-dilate with a small balloon, and we put the DCB at the side branch, which is the circumflex, and we did the KBT and port later. And then we achieve quite good flow from both LAD and the circs. So in this situation, we don't want to keep the time of the procedures longer, because the patient is quite elderly, and she cannot tolerate with any longer procedure as well. The next case we have like DCB for the CTOs, where we have our circs. We have circs, which is quite diffuse lesion, and we have to use Gaia to pass the lesion, and we pre-dilate with small balloon from 10 to 2.5, and for the later angio, we did 2 DCB balloon from the proximal to the distal of the circs, and we achieve good flow without stenting. Sorry for the videos. Can you click on the video? And this is the third case with also a high with a 70-year-old female, and with ACS and multivessel disease, and past medical history of hypertension and type 2 diabetics. And she has also femoral neck fracture surgery 2 months ago. And she was on high bleeding risk. So em bấm video anh.
Video is not running. That's why.
Okay. Okay, yeah, so, and this is the case of DCB for the STEMI patient. She has the corporate lesion of the right coronary artery, and she has very tight stenosis of the mid RCA and diffuse disease of the distal RCA. So we did the hybrid strategy, which was stenting at the mid part and a DCB of the distal part. And she avoided with the 2 stent strategy, as previously we have done in our daily practice. second. Okay, so the video is not working very good, so I try to pass this through. So the key message is complex hybrids and indicated PCI is not uncommon in daily practice, and hybrid DS plus DCB should be favored, and we are having quite ongoing large data for this, and the data is still waiting. Thank you for your.
We go to the next, and then we do a discussion.
Yeah. Thank you very much. We'll go to the next speaker, and we'll come back and take some questions. Yeah. Thank you, Dr. Kwok.